So this is SOT video 1. First thing I'm going to do is do a distortion analyzer. So have you face the window for me over there. I'm going to put my thumb on the second sacral tuberosity, and I'm going to look for lateral sway. And if I see lateral sway greater than a quarter inch in this direction, that would be indicative of a category 2. And then I'll have the patient turn this direction. I'm going to put my thumb down on the acromion, looking for sway greater than a quarter inch. And if I see sway greater than a quarter inch, that would be indicative of a category 1. If there was no sway but an antalgic lean, that would be indicative of a category 3. Next, we're going to do a first rib palpation. So I'm going to put my sip on the first rib, my thumb's on the TVP. I'm going to have the patient slowly flex and extend the head for me. Thank you. And if I feel movement more than a quarter inch bilaterally, then that would be a category 1. Unilaterally, that would be category 2. With no movement, that would be a category 3. Okay, now I'm going to have the patient lay down supine for me. We're going to do some cervical indicators. So I'll be palpating the cervical spine. If I find a bilateral tenderness on the C3 lamina, that would be indicative of a category 1. And if I palpated C4 left lamina and that was tender, then that would be indicative of a category 2. Palpating the rest of the cervical spine, if I find tenderness elsewhere, then we follow the Levitt Brothers protocol. So C1 would correlate to L5, C2 would correlate to L4, so on and so forth. And the TVPs would, on like a C1 would indicate, or a C2 would indicate a mammillary issue on L5. If it was a spinous, then it would be a TVP issue on L5 or L4. I'm sorry. Next, then we'll do the cervical compaction. So I'll have the patient bring his legs together, hands on the stomach. I'll lift the head, and I'll have you go ahead and lift your legs about 12 to 24 inches for me. Perfect. And now I will press, and I'll have you do the same thing. And it seemed like it was easier. So then what we're going to do is we're going to do the stair step. So this will give me an indication of locking at each cervical joint. So T1, we'll start with T1, C7, and then move on up to C1, C2. And then if I find a joint that doesn't lock out, then I would go ahead and do a figure 8 there. If I found a problem with T1, C7, then we would have an anterior thoracic at T1 through T4. So I would go ahead and palpate that and then make the adjustment. Okay. Now we're going to do a basic one. So what I'm going to do is I'm going to take my 4 fingers and place them laterally to the EOP, right below the occiput, and then I'm going to feel for a balancing out of the flow or energy. Then after that, I'm going to palpate the sagittal suture. We'll find a tender spot. I'll take my fingers like this, place it over that tender spot with my fingers on the parietal bone, and as the patient inhales, I will go ahead and lift 3 times, and then repalpate, looking for tenderness, and that should be fixed. Next, we'll do the psoas test. So I'm going to have you bring your hands back towards me, and I'm going to pull, closing my eyes, put the hands together, bring up, show the patient. This one looks short. So have the patient lift his knee for me, your leg on the table. Ask permission if I can put my hand through your leg there. So I'm going to grab lateral, set the hip, and then I'll palpate the psoas. And I'll have the patient breathe in and out 3 times. And I'll go deeper to the psoas the second time. And then on the 3rd time, I will actually hit the psoas, and then I'll work the psoas back and forth. Okay? And then we'll come back and retest. Bring your arms up for me and pull back, extend your hands, put them together, and then show the patient that the hands are even again. Next is the anterior iliofemoral ligament. So what I'm going to do is I'm going to try and internally rotate the patient's legs. His right leg did not quite rotate in to 40 degrees. So what I'll do is I'll come over to this side and I'm going to palpate above the greater trochanter for the iliofemoral ligament, and then I'll have the patient internally rotate his leg, and as I pull on that iliofemoral ligament, he'll slowly rotate his leg out. We'll do that once, twice, and then the third time we're going to do a count of 3, and it's going to be a quick one. So 1, 2, 3, boom. So then we'll go back and take a retest, and they're even on both sides. Next is the arm fossa test. So what I'm going to do is go ahead, make a nice soft fist, and then we're going to test that. So we have a good muscle right there. So if you do me a favor and find your palpate for your pubic bone right there. Perfect. So we'll find the ASIS is right there. So what I'm going to do is I'm going to go ahead and palpate that inguinal ligament. I'm going to pull on that while I test the muscle, and it's strong, and then test it again. Further down the inguinal ligament, and that's strong. Next we'll go to the other side. We're going to check this muscle right here, make sure it's nice soft fist, make sure it's strong. Could you put your hand down for me? That was nice and strong. So what we'll do is I'll have you palpate your pubic bone for me again, and I'll find right there. Perfect. So I'm going to get the inguinal ligament. I'm going to push on that, test, nice and strong, test again, nice and strong. If either of those would have been tender, or if either of those would have made the muscle test weak, then that would have been a positive arm fossa test, and that would be a category 2.